Operational blindness. The silent crisis undermining perioperative efficiency, patient safety, and workforce stability. By Dr. Jake Taylor Jacobs. Operations Engineer and COO, SIPS Healthcare Solutions. Executive Summary. Every hospital administrator can recite their operational challenges with precision. Staffing shortages plague their schedules, or delays disrupt their case flow. Instrument errors compromise their quality metrics. Sterilization breakdowns trigger their incident reports. Vendor inconsistencies undermine their efficiency. Documentation failures expose them to regulatory risk. These leaders are not wrong to identify these problems. They're simply looking at symptoms while the disease remains invisible. Beneath every delayed case, every missing instrument, every preventable error, and every departing staff member lies a much deeper, much more damaging condition that has gone unnamed and therefore untreated in healthcare operations. This condition costs hospitals millions annually, drives away talented professionals, threatens patient safety, and turns even the most capable leaders into perpetual firefighters. We call this condition operational blindness. Operational blindness is the systemic inability of leaders, teams, and integrated systems to see what is happening in real time, understand why it is happening, or predict what is about to happen next inside the perioperative workflow. It transforms small, manageable issues into sudden crises. It makes prevention impossible and improvement unsustainable. Most critically, it persists because the healthcare industry has been treating symptoms with solutions designed for a fundamentally different problem. This white paper accomplishes 4 objectives. First, it defines operational blindness as a distinct condition separate from the operational challenges it produces. Second, it demonstrates why traditional approaches, particularly instrument tracking systems and process documentation, cannot cure this disease and may actually perpetuate it. Third, it quantifies the financial, safety, and human costs of allowing operational blindness to persist. Fourth, it introduces the only viable path forward, a fundamental shift from reactive tracking to perioperative operations intelligence. The stakes could not be higher. With OR time costing between $36 and $133 per minute, Superscript 1 case cancellations eliminating thousands of dollars per incident, Superscript 2 and workforce turnover draining an average of $56,300 per departed registered nurse. Superscript 3 operational blindness represents one of the largest unrecognized cost centers in the modern hospital. More importantly, it creates the conditions for preventable patient harm in an environment where 83% of sterile processing errors stem from failures in visualization, errors that current systems cannot detect until after they occur. The hospital that learns to see will lead. The hospital that remains blind will continue fighting battles it cannot win. Section 1. Defining operational blindness. Operational blindness is a systemic condition that occurs when a department loses the ability to detect problems early, recognize recurring patterns, or predict upcoming failures. It manifests when leaders cannot identify true workload realities, assess competency gaps accurately, or forecast staffing needs with confidence. It persists when organizations cannot quantify true cycle times, understand the root causes of human error, or monitor compliance in real time. This condition is not caused by incompetent staff or insufficient effort. It is caused by invisible operations, by workflows that unfold without adequate visibility, by processes that fail without clear warning signals, and by problems that build silently until they erupt into crises. The sterile processing department and the operating room represent 2 of the most complex, interdependent environments in the modern hospital. Instruments move through intricate workflows involving decontamination, assembly, sterilization, storage, and delivery. Each step demands precision. Each handoff creates risk. Each deviation from standard work has consequences that may not manifest until a surgical case begins. Yet, despite this complexity, most facilities operate these critical departments with minimal real-time visibility into what is actually happening. They are blind to instrument availability until the OR calls looking for a missing tray. They are blind to workflow gaps until delays cascade through the schedule. They are blind to OR speedy communication breakdowns until tensions boil over in confrontational exchanges. They are blind to leadership imbalances until key personnel burn out and resign. They are blind to training deficiencies until errors appear in incident reports. They are blind to vendor inconsistencies until late deliveries disrupt case preparation. They are blind to real-time risk until patient safety is compromised. They are blind to future delays until the delay has already occurred. Most critically, they are blind to the next preventable breakdown until prevention is no longer possible. This blindness creates a dangerous illusion. Small problems appear as sudden emergencies. Predictable patterns look like random occurrences. Systemic failures feel like isolated incidents. Leaders who would never tolerate flying blind in other aspects of hospital operations find themselves managing perioperative services with little more than retrospective data, incident reports, and the institutional memory of long-tenured staff members who have learned to sense when something feels wrong. The problem is not that hospitals lack data. Most facilities generate enormous volumes of operational data through their tracking systems, their electronic health records, and their quality management platforms. The problem is that data without intelligence is simply noise. Hospitals are drowning in information while starving for insight. They can tell you what happened yesterday, but they cannot tell you what is about to happen in the next hour. They can document failures with extraordinary detail, but they cannot prevent them with equal precision. Section 2. Why tracking systems cannot solve operational blindness. For 2 decades, hospitals have invested heavily in instrument tracking systems and workflow management software, believing these technologies would solve their operational challenges. Vendors have marketed these solutions as comprehensive answers to perioperative inefficiency. Administrators have allocated substantial capital budgets to their implementation. Yet operational blindness persists and in some cases intensifies despite these investments. The reason is fundamental. Tracking is reactive by design, while intelligence is predictive by nature. Tracking systems excel at documenting what happened. They create detailed records of instrument movements, sterilization cycles, and case completions. They generate reports that satisfy regulatory requirements and provide data for retrospective analysis. What they cannot do, what they were never designed to do, is tell you what is about to happen. This limitation stems from several inherent characteristics of traditional tracking approaches. First, these systems depend entirely on perfect human behavior for data accuracy. Every instrument must be scanned at every transition point. Every exception must be documented in real time. Every process deviation must be recorded by staff members who are already managing high workloads and time pressure. When humans are busy, stressed, or simply accustomed to workarounds, data integrity suffers. The system shows you a version of reality that may bear only passing resemblance to what actually occurred. Second, tracking systems capture data only after events have occurred. An instrument becomes lost after it has already been misplaced. A sterilization cycle failure is recorded after the load has already been compromised. A case delay is documented after the surgeon has already been kept waiting. This retrospective orientation makes these systems excellent for root cause analysis following incidents, but useless for prevention. You cannot prevent what you cannot see coming. Third, and perhaps most critically, tracking systems cannot identify why errors occurred or what factors contributed to their occurrence. They can tell you that a tray arrived late to the OR, but they cannot tell you whether the delay stemmed from decontamination workflow congestion, sterilizer capacity constraints, staff competency gaps, vendor delivery problems, or communication breakdowns between departments. Without understanding causation, improvement efforts become guesswork. Hospitals address symptoms while root causes continue generating new problems. Fourth, these systems do not see leadership gaps or organizational factors that create conditions for failure. They cannot identify when a supervisor is overwhelmed, when a manager lacks training in crucial competencies, when an educator has been pulled from training duties to cover staffing shortages, or when communication patterns between departments have deteriorated. They track instruments and processes, but remain blind to the human and organizational dynamics that determine whether those processes function effectively. Fifth, tracking systems do not understand competency levels or learning curves. They treat every technician as interchangeable, every shift as equivalent, and every workflow as standardized. They cannot tell you that a particular staff member is struggling with complex instrument sets, that a specific shift consistently experiences higher error rates, or that certain vendor instruments require specialized knowledge that only a subset of your team possesses. This blindness to human factors makes it impossible to target training, adjust assignments, or predict which situations will likely produce errors. Sixth, traditional tracking approaches cannot integrate the real communication patterns that exist between OR and SPD. They document formal processes, but miss the informal exchanges, the workarounds, the frustrations, the information gaps, and the relationship dynamics that determine whether two departments function as an integrated system or as adversaries. Communication breakdowns often precede operational failures, but tracking systems provide no visibility into these warning signs. Seventh, these systems cannot forecast shortages, predict constraints, or model labor loads. They show current status, but cannot project future states based on scheduled cases, anticipated instrument demand, staff availability, sterilizer capacity, and vendor reliability. Leaders using these systems are like drivers watching through the rearview mirror, seeing clearly where they have been while remaining blind to what lies ahead. Finally, tracking systems cannot predict delays or model the cascading effects of small disruptions. They treat each event as isolated rather than recognizing the interconnected nature of perioperative workflows where a single bottleneck can trigger a chain reaction of problems throughout the day. In essence, tracking systems record accidents after they occur. They document failures with precision but prevent nothing. They create an illusion of control through data abundance, while operational blindness continues unchecked. Hospitals that rely solely on tracking are essentially managing by autopsy, conducting detailed post-mortem analyses on every failure while remaining unable to prevent the next one. The healthcare industry has confused documentation with intelligence, mistaking the ability to record events for the ability to understand and influence them. This confusion has led to decades of investment in systems that address a fundamentally different problem than the one hospitals actually face. Hospitals need visibility, prediction, and prevention. What they have purchased is documentation, retrospection, and incident management. Section 3. The 6 root causes of operational blindness. Understanding why operational blindness persists despite significant investments in technology and process improvement requires examining the fundamental conditions that create and sustain it. 6 root causes, often operating in combination, prevent organizations from achieving the operational visibility necessary for excellence in perioperative services. The absence of predictive insight. Hospitals excel at retrospective analysis. They can produce detailed reports on what failed, when it failed, and who was involved in the failure. Quality departments conduct thorough root cause analyses following incidents. Performance improvement teams generate metrics tracking historical trends. Compliance officers document adherence to established protocols. Yet, despite this analytical capability, most organizations possess virtually no ability to predict what will fail before failure occurs. This absence of predictive insight forces leaders into perpetual reaction mode. They learn about problems after patients have been affected, after surgeons have been inconvenienced, after costs have been incurred, and after staff morale has been damaged. They identify patterns only after those patterns have repeated multiple times. They recognize warning signs only in hindsight when reviewing what preceded a crisis. This reactive orientation makes prevention structurally impossible. You cannot prevent what you cannot foresee. Fragmented communication between OR and SPD. The relationship between operating rooms and sterile processing departments should function as a seamlessly integrated system. In reality, it typically operates as 2 separate domains with minimal mutual visibility and frequent miscommunication. The OR sees symptoms of SPD problems, late instruments, missing items, incorrect configurations, but lacks understanding of the underlying workflow constraints, capacity limitations, or process challenges that produce those symptoms. The SPD experiences intense pressure from OR demands, but receives little information about actual case requirements, schedule changes, or priority shifts until the last possible moment. This fragmentation creates a dangerous situation where nobody sees the complete system. The OR makes requests without understanding their impact on SPD workflows. The SPD processes instruments without full context about their urgency or specific case requirements. When problems occur, each department interprets events through its own limited perspective, often reaching conflicting conclusions about root causes and appropriate solutions. Finger-pointing replaces problem-solving. Workarounds replace sustainable fixes. Relationships deteriorate as trust erodes. The absence of integrated visibility means that system-level optimization becomes impossible. Improvements in one department may inadvertently create problems in the other. Process changes made with good intentions produce unintended consequences that remain invisible until they manifest as failures. Leaders in both areas work diligently, but cannot achieve lasting improvement because they lack the system-wide perspective necessary for effective decision-making. Leadership gaps and role overload. Effective leadership requires the capacity to think strategically, plan proactively, and guide teams toward long-term goals. Yet many perioperative leaders find themselves trapped in a cycle of tactical firefighting that leaves no bandwidth for strategic leadership. Managers are underwater with administrative responsibilities, regulatory compliance requirements, and operational crisis management. Supervisors spend their days resolving immediate problems, mediating conflicts, and covering staffing gaps rather than coaching teams and improving processes. Educators, who should focus on building competency and developing talent, get pulled into staffing assignments to meet minimum coverage requirements. This role overload creates a leadership structure that operates entirely in the present tense. Leaders can see what is happening now, or more accurately, what happened in the last few hours, but they cannot see forward. They cannot identify trends that will become problems in the coming weeks. They cannot develop staff members who will become tomorrow's leaders. They cannot redesign workflows that will prevent recurring failures. They cannot build the relationships and communication systems that would enable true OR-SPD integration. The problem compounds over time as constant firefighting burns out capable leaders, driving them to resign or transfer to less chaotic environments. Their institutional knowledge departs with them, leaving less experienced leaders to navigate the same dysfunctional patterns without the benefit of accumulated wisdom. Organizations lose not just individuals, but the collective intelligence those individuals carried about how the system actually works, where the landmines hide, and which informal workarounds keep everything functioning. Competency assumed rather than measured. Perhaps no assumption in perioperative services is more dangerous than the belief that trained staff are competent staff. Hospitals invest in orientation programs, provide initial training, and then largely assume that staff members know how to properly identify instruments across multiple vendor sets, follow appropriate decontamination cycles for different instrument types, operate sterilization equipment according to validated parameters, conduct thorough inspections that catch subtle defects, and navigate the full complexity of vendor-specific processing requirements. This assumption of competency persists despite high turnover, frequent updates to instruments and procedures, increasing complexity in surgical instrumentation, and the reality that competency is not a binary state, but a continuum that requires ongoing validation and development. When competency is assumed rather than measured, organizations lose visibility into one of the most critical factors determining operational outcomes. They cannot identify when a staff member is struggling with specific instrument sets until errors appear in the OR. They cannot recognize knowledge gaps that will produce failures tomorrow. They cannot target training resources to the areas of greatest need. They cannot make informed decisions about assignments, scheduling, or process design because they lack reliable information about the actual capabilities of their workforce. This blindness to competency extends beyond individual skills to encompass team dynamics, communication patterns, and collective problem-solving capacity. Organizations do not know which teams function effectively together, which combinations of personnel produce higher error rates, or which shifts consistently struggle with specific types of cases. They manage staffing as if people are interchangeable components rather than recognizing that competency, chemistry, and communication determine outcomes as much as procedures and equipment. Vendor variability. Sterile processing departments do not operate in controlled environments with standardized inputs. They process instruments from multiple vendors, each with unique configurations, specialized requirements, and specific instructions for use. They receive consignment sets that may vary in contents from one delivery to the next. They cope with late arrivals that compress processing timelines. They manage incomplete documentation that leaves critical questions unanswered. They discover foreign items mixed into expected sets. They receive last-minute additions and changes that invalidate carefully planned workflows. This vendor variability creates a constant state of uncertainty that traditional systems cannot adequately address. Standard work becomes impossible when the work itself is not standard. Process optimization efforts struggle when processes must continuously adapt to unpredictable inputs. Quality control suffers when the definition of correct varies by vendor, by set, and sometimes by delivery. The result is a persistent fog over SPD operations, an environment where even the most capable team cannot achieve consistent performance because the inputs themselves are inconsistent. Organizations operating with operational blindness cannot effectively manage this variability because they lack the visibility needed to identify patterns in vendor performance, quantify the operational impact of vendor issues, or hold vendors accountable with data-driven evidence. Problems get addressed reactively, if at all, while the underlying patterns of vendor unreliability continue generating operational disruptions. Outdated systems masquerading as innovation. The healthcare technology market has produced what appears to be steady innovation in perioperative management systems. New products launch regularly, featuring improved user interfaces, cloud-based architectures, mobile accessibility, and integration capabilities. Marketing materials promise transformation. Demonstrations showcase impressive features. Yet beneath these modern exteriors, many systems continue operating on the same fundamental logic that governed their predecessors decades ago. These systems track instruments through defined checkpoints. They document sterilization cycles. They generate compliance reports. They create dashboards showing historical metrics. They do all of this more efficiently and with better aesthetics than older systems, but they do not do anything fundamentally different. They remain reactive, retrospective, and unable to provide the predictive intelligence that would enable prevention rather than documentation. Hospitals invest substantial capital in these upgrades, believing they are purchasing innovation when they are actually purchasing user interface improvements wrapped around legacy thinking. The promise of transformation generates executive sponsorship and funding. The reality of familiar limitations becomes apparent only after implementation, when leaders discover that their new system produces better-looking reports on the same old problems. By then, the investment has been made, the vendor relationship established, and organizational energy for additional change exhausted. Operational blindness persists, now documented more efficiently than before. Section 4. The impact of operational blindness on hospitals. The financial, operational, and human costs of operational blindness are staggering. Yet they remain largely invisible because they manifest as distributed problems across multiple departments and cost centers rather than as a single line item in the budget. Understanding the true impact requires examining how this condition affects every dimension of perioperative performance. Or delays and cancellations. Operational blindness leads directly to case disruptions through missing instruments, incomplete trays, late arrivals, and last-minute scrambles that compress preparation time and create cascading delays. The financial impact of these disruptions is substantial and well-documented in healthcare operations research. Operating room time represents one of the most expensive resources in the hospital. Multiple peer-reviewed studies have established that the mean cost of OR time ranges from $36 to $37 per minute when examining comprehensive financial data from California hospitals, with direct costs accounting for approximately 54 to 59% of total expenses. Superscript 1. Other research examining OR costs across different procedure types and complexities has found that costs can range from $22 to $133 per minute, with an average of $62 per minute, variation that reflects differences in case complexity. Staffing requirements and time of day. Superscript 2. Superscript 3. A comprehensive literature review analyzing 14 independent studies found an average OR cost of $46.04 per minute, with substantial variation reflecting the diversity of hospital types and geographic locations. These per-minute costs translate into significant financial impact from delays. A 10-minute delay costs between $360 and $1,330. A 30-minute delay costs between $1,080 and $3,990. A single hour of lost OR time costs between $2,160 and $7,980. When operational blindness creates conditions where delays become routine rather than exceptional, these costs accumulate rapidly across hundreds or thousands of cases per year. Case cancellations represent an even more severe financial impact. Research examining day of surgery cancellations has established that potential losses range from $2,000 to $10,000 per canceled case, depending on the procedure type and the resources already committed. Industry analysis has shown that facilities with cancellation rates exceeding 1% have significant improvement opportunities. Yet many hospitals experience rates of 5 to 8% or higher, rates that indicate systemic problems in scheduling, patient preparation, and resource coordination. The COVID-19 pandemic provided stark evidence of surgery's financial importance to hospital operations. Research examining the economic impact of canceled elective procedures found that such cancellations resulted in estimated losses of $16.30 to $17.70 billion per month in reimbursement to the U.S. hospital system. Broader analysis using insurance claims from 161 million enrollees established that elective surgical cases contribute 78%, approximately $1.1 trillion, to inpatient hospital plus outpatient surgical gross revenue per year. The average hospital loses 19 hours of OR time per month due to cancellations, while ambulatory surgery centers lose an average of 5 hours per month. These statistics underscore a fundamental reality. Surgical services represent the financial engine of most hospitals, and any condition that disrupts surgical flow has immediate and substantial financial consequences. Operational blindness creates the conditions for these disruptions by preventing the predictive visibility needed to prevent delays and cancellations before they occur. Patient safety risk. Blind processes generate blind errors, which in turn create preventable patient safety incidents. The relationship between operational visibility and patient safety is not theoretical. It is documented in research examining actual error patterns in sterile processing and perioperative services. Research analyzing surgical instrument errors has revealed that 83% of reported errors are related to failures in visualization, specifically in tasks like inspection, identification, and assembly of surgical instruments. Superscript 1. These errors, which include misdetection of bioburden, incomplete instrument assembly, and missing instruments, stem primarily from the inherent limitations of human visual capabilities, particularly under the stress and high-throughput demands of the sterile processing environment. The research further found that bioburden or contamination errors, debris, blood, tissue, and hair left on instruments account for nearly 69% of documented mistakes. The reporting of these errors reveals another dimension of the visibility problem. Only 20.4% of patient safety notice incident reporting forms are fully completed, and 15% are submitted days after the event. Superscript 1. This delay in reporting suggests that the manual nature of data entry into non-integrated systems creates barriers to capturing accurate, timely information about safety events, a problem that perpetuates operational blindness by preventing organizations from recognizing patterns until well after they have caused harm. The broader context of medical errors in healthcare underscores the urgency of improving operational visibility. Medical errors have been reported as the third leading cause of death in the United States, with approximately 400,000 hospitalized patients experiencing preventable harm each year. Superscript 1 hospital-acquired infections alone cost the healthcare system between $35.70 and $45 billion annually, with 1 in 17 patients who contract a healthcare-associated infection dying as a result. Communication breakdowns between SPD and the operating room contribute significantly to these risks. Surgical delays can occur when missing or incorrect instruments are discovered during operations, increasing not only the time patients remain under anesthesia but also the risk of complications from extended procedures. Superscript 2 The Joint Commission has responded to these risks by strengthening infection control standards, now requiring facilities to maintain separate policies addressing cleaning, disinfection, and sterilization of reusable medical and surgical devices, and to conduct proactive risk assessments identifying gaps in compliance with evidence-based guidelines. The critical insight is that patient safety in perioperative services depends not merely on compliance with protocols, but on visibility into whether those protocols are being followed effectively. Operational blindness creates an environment where errors can occur, propagate, and cause harm without detection until the moment of patient impact. Workforce turnover. Blind systems burn out staff because they force constant reaction mode. When employees cannot predict workflow, cannot access the information they need to perform effectively, and cannot see how their efforts contribute to larger outcomes, they experience the chronic stress that leads to burnout and eventual departure. The data on healthcare workforce turnover reveals a system in crisis. The hospital turnover rate stands at 18.3 to 20.7% in 2024, with some facilities experiencing rates as high as 38%. Superscript 1 registered nurse turnover specifically is 16.4 to 18.4%, with surgical services experiencing turnover rates around 15.4%. Superscript 1 These statistics, while concerning on an annual basis, become truly alarming when examined cumulatively. In the past 5 years, hospitals have turned over 106.6% of their staff, essentially replacing their entire workforce while attempting to maintain operational continuity. Certain departments face particularly acute challenges. Emergency services, step-down units, and telemetry departments experience cumulative turnover rates of 112 to 120% over 5 years, meaning they will turn over their entire staff in less than 4.5 years. Superscript 1 This constant churn prevents the development of institutional knowledge, disrupts team cohesion, and creates perpetual training burdens that strain remaining staff. The financial impact of this turnover is substantial. The average cost of turnover for one staff-registered nurse is $56,300, with hospitals losing between $3.90 and $5.8 million per year on RN turnover alone. Superscript 1. Superscript 2 These costs encompass recruiting expenses, signing bonuses, training programs, decreased productivity during transition periods, and overtime paid to existing staff covering gaps. Voluntary terminations account for 95.4% of all hospital separations, indicating that staff are choosing to leave rather than being forced out. Only 20% of healthcare employers report experiencing low turnover, with high turnover rates being identified as the most significant operational challenge facing the industry. Superscript 2 Superscript 1 The situation is particularly severe in rural areas, where 29% of employers cite trouble filling high turnover positions. Additionally, nearly 1 in 5 employers have dealt with first-day no-shows, candidates who accept positions but never appear for their first day of work, indicating deeper problems with job attractiveness and employee expectations. Research has established a direct link between nurse turnover and patient outcomes. Lower nurse turnover rates are associated with fewer patient falls and lower costs, with hospitals saving between $105,000 per year for smaller facilities and $616,000 annually for larger hospitals when they reduce turnover effectively. Superscript 2 This connection between workforce stability and patient safety underscores that addressing operational blindness is not merely an operational improvement initiative, it is a patient safety imperative. The relationship between operational blindness and workforce turnover creates a vicious cycle. Blind systems generate chaos and burnout, which drives turnover. Turnover reduces institutional knowledge and team stability, which exacerbates operational problems. Worsening operational problems increase stress and burnout, which drives additional turnover. Breaking this cycle requires addressing the root cause, the lack of operational visibility that makes work feel chaotic, unpredictable, and unmanageable. Leadership breakdown. When leaders cannot see what is coming, they cannot lead effectively. They become crisis managers rather than strategic thinkers, spending their time fighting fires rather than preventing them. This leadership breakdown manifests in multiple ways that compound over time. Leaders operating with operational blindness lack the information needed to make informed decisions. They cannot accurately assess capacity constraints, evaluate staff competency, or predict resource needs. Their decisions are based on incomplete information, intuition, and the hope that past patterns will continue. When those decisions produce poor outcomes, they cannot determine whether the problem was with the decision itself, the execution, or factors beyond their control. This information deficit prevents effective performance management. Leaders cannot provide meaningful feedback to staff when they lack objective data on performance. They cannot identify top performers who deserve recognition or struggling employees who need support. They cannot distinguish between individual competency issues and systemic problems. Performance evaluations become subjective exercises based more on personality and politics than actual contribution to outcomes. The constant crisis management creates a leadership culture that values reactive problem solving over proactive improvement. Leaders who excel at firefighting get rewarded and promoted, while those who focus on prevention and long-term improvement may be viewed as insufficiently responsive to immediate needs. This cultural dynamic perpetuates operational blindness by making it the expected mode of operation rather than a problem to be solved. Furthermore, leaders trapped in firefighting mode cannot develop their teams effectively. They lack time for coaching, mentoring, and developing the next generation of leaders. They cannot create the relationships and trust needed for effective collaboration between departments. They cannot build organizational capabilities that would enable sustained excellence. The leadership pipeline dries up as potential leaders watch current leaders drowning in operational chaos and decide to pursue opportunities elsewhere. Financial leakage. Beyond the direct costs of delays, cancellations, and turnover, operational blindness creates multiple forms of financial leakage that are difficult to quantify precisely because they are distributed across many cost centers and often go unrecognized as preventable expenses. Labor utilization inefficiency occurs when staff spend time searching for missing instruments, resolving preventable problems, performing rework due to errors, and managing unnecessary complications. These activities consume hours that could have been spent on productive work, yet they rarely appear as distinct line items in financial reports. Instead, they manifest as lower productivity, higher overtime costs, and the need for more staff than would be required with efficient operations. Excessive overtime costs accumulate when delays and inefficiencies push work beyond scheduled shift hours. Agency staffing premiums, often 50 to 100% higher than regular staff costs, become necessary to cover gaps created by turnover and burnout. These premium labor costs represent pure financial waste when compared to the cost of stable, well-functioning operations. Reprocessing failures and rework create hidden costs throughout the system. Instrument sets that must be reprocessed due to contamination, wet packs, or procedural errors consume sterilizer capacity, staff time, and consumable supplies while producing no value. The opportunity cost of this wasted capacity can be substantial when it delays needed instruments or requires expedited processing that disrupts planned workflows. Lost or damaged instruments require replacement at costs ranging from hundreds to tens of thousands of dollars per instrument. When operational blindness prevents effective tracking and accountability, these losses accumulate without clear visibility into their causes or opportunities for prevention. Vendor management complications create additional costs. When organizations lack data on vendor performance, they cannot effectively negotiate contracts, hold vendors accountable for late deliveries or incomplete documentation, or make informed decisions about vendor relationships. They pay premium prices for unreliable service because they cannot quantify the operational impact of vendor problems. When these various forms of financial leakage are considered together, or time at $36 to $133 per minute, average RN turnover costing $56,300 per position, case cancellations costing $2,000 to $10,000 each, and surgical cases contributing 78% of hospital revenue. Operational blindness emerges as one of the largest unrecognized cost centers in perioperative services. The cumulative effect represents millions in preventable costs for mid-sized hospitals and tens of millions for larger health systems. Section 5. Why hospitals have not fixed this problem. If operational blindness is so damaging and so costly, why has the healthcare industry failed to solve it? The answer lies in a fundamental misunderstanding of the problem itself and persistent confusion about the difference between data and intelligence. For decades, the healthcare technology industry has sold solutions to hospitals under the premise that better data capture would solve operational problems. Hospitals bought dashboards that display historical metrics. They implemented tracking systems that document instrument movements. They deployed audit tools that verify protocol compliance. They installed workflow screens that show current status. Each purchase came with promises of improved efficiency, better quality, and reduced costs. These investments produced exactly what they were designed to produce: more data. Hospitals now generate enormous volumes of operational information. They can tell you how many cases ran yesterday, how many instruments were processed last week, and what percentage of trays passed inspection last month. They have reports covering every conceivable metric, dashboards displaying trend lines and color-coded indicators, and data warehouses storing years of historical information. Yet operational blindness persists because the industry confused data with intelligence. Data tells you what happened. Intelligence tells you why it happened, what will happen next, and what you should do about it. Hospitals invested in data systems when they needed intelligence systems. They bought better rearview mirrors when they needed windshields. This confusion stems partially from the technology industry's success in other domains. In many business contexts, better data does lead to better decisions. When you can see what products are selling, what customers are buying, and what trends are emerging, you can make informed decisions about inventory, pricing, and strategy. But perioperative operations are fundamentally different from retail sales or supply chain logistics. They involve complex human factors, interdependent processes, unpredictable variables, and time-critical decision-making under uncertainty. In this environment, historical data provides limited value for preventing future problems. The siloed nature of hospital operations has also prevented recognition of operational blindness as a systemic problem. The OR experiences delays and blames SPD for late instruments. SPD experiences impossible demands and blames OR for unrealistic expectations. Administrators see high costs and turnover, but attribute them to staffing market conditions rather than operational dysfunction. Quality departments document incidents, but focus on protocol compliance rather than system-level visibility. Each group sees part of the problem from its own perspective, but nobody recognizes the common root cause connecting all these symptoms. Additionally, the healthcare industry's orientation toward compliance and risk management has directed investment toward documentation rather than prevention. Regulatory requirements emphasize the ability to demonstrate that proper procedures were followed, not the ability to prevent problems from occurring in the first place. This compliance focus has driven demand for systems that create audit trails and generate reports for surveyors, rather than systems that provide real-time intelligence for preventing failures. The technology limitations of earlier generations also created expectations that have persisted even as technical capabilities have advanced. 20 years ago, predictive analytics, real-time processing, and integrated intelligence systems were technically infeasible or prohibitively expensive for most hospitals. The industry adapted to these limitations by building workarounds and accepting reactive management as unavoidable. Even as technology has evolved to make intelligence systems possible, organizational expectations and vendor business models have remained anchored to the data paradigm. Leadership turnover and bandwidth constraints have prevented sustained focus on solving the underlying problem. When perioperative leaders are constantly managing crises, they lack the time and energy to step back and question whether they are solving the right problem. When new leaders arrive, they inherit existing systems and often assume that if the organization invested substantially in technology, it must be adequate for the need. The daily operational demands consume all available attention, leaving no capacity for fundamental rethinking. Finally, the absence of a clear problem definition has prevented the industry from recognizing operational blindness as a distinct condition requiring a specific solution. Without a name for the disease, hospitals have continued treating symptoms. They hire more staff to cover inefficiency. They implement additional training to address competency gaps. They purchase new tracking systems to document problems more thoroughly. Each intervention addresses a symptom while the underlying condition persists. The healthcare industry has not solved operational blindness because it has not recognized operational blindness as the problem. It has been treating staffing shortages, training deficiencies, and documentation gaps when the actual problem is systemic invisibility. You cannot solve a problem you have not named. Section 6. The solution: perioperative operations intelligence. Solving operational blindness requires a fundamentally different approach than the tracking and documentation systems that have dominated perioperative technology for the past 2 decades. The solution is not better data, it is intelligence. Not documentation of the past, but visibility into the future. Not reactive incident management, but proactive prevention. We call this solution perioperative operations intelligence, and it represents a category-defining shift in how hospitals understand and manage perioperative workflows. Perioperative operations intelligence is characterized by 4 core capabilities that distinguish it from traditional tracking approaches: predictive visibility, causal understanding, human factors integration, and automated intelligence. Each capability addresses specific limitations of existing systems while creating new possibilities for operational excellence. Predictive visibility. The foundation of perioperative operations intelligence is the ability to see what is coming before it arrives. This requires systems that model future states based on current conditions, historical patterns, scheduled demands, and known constraints. Rather than simply tracking where instruments are now, intelligent systems predict where they will be, whether they will arrive on time, and which factors might cause delays. This predictive capability transforms how leaders manage operations. Instead of learning about problems after they occur, leaders receive early warnings while intervention is still possible. Instead of reacting to delays, they prevent delays by addressing bottlenecks before they impact case flow. Instead of discovering shortages when the OR calls looking for instruments, they receive alerts hours earlier when the shortage becomes predictable based on case schedules and processing capacity. Predictive visibility extends beyond instrument logistics to encompass staffing adequacy, competency match, vendor reliability, sterilizer capacity, and workflow congestion. It enables leaders to ask not just what is happening now, but what will happen in the next 2 hours, and what should I do about it? This shift from present to future tense enables prevention rather than reaction. Causal understanding. Intelligence requires understanding not just what happened, but why it happened. Perioperative operations intelligence incorporates causal analysis that identifies root causes rather than simply documenting symptoms. When a tray arrives late to the OR, the system does not merely record the delay, it analyzes whether the cause was decontamination workflow congestion, sterilizer capacity constraints, staff competency gaps, vendor delivery problems, communication failures, or some combination of factors. This causal understanding transforms improvement efforts from guesswork to precision. Leaders can target interventions at actual root causes rather than addressing symptoms. They can distinguish between one-time anomalies and recurring patterns. They can identify which problems require training solutions, which require process redesign, which require technology investment, and which require vendor management. Furthermore, causal intelligence enables learning systems that improve over time. As the system observes which factors consistently precede delays, errors, or other problems, it refines its predictive models to provide more accurate forecasts and more actionable recommendations. The intelligence grows more sophisticated with use, continuously adapting to the unique patterns and challenges of each organization. Human factors integration. Traditional tracking systems treat human factors as noise in the data, variation to be minimized rather than insight to be leveraged. Perioperative operations intelligence recognizes that human factors determine outcomes as significantly as processes and equipment. It incorporates competency levels, learning curves, team dynamics, communication patterns, cognitive load, and work design into its analytical framework. This integration enables capabilities that traditional systems cannot provide. The system can identify when a staff member is struggling with specific instrument sets and route those sets to more experienced technicians. It can recognize when particular team combinations produce higher error rates and adjust assignments accordingly. It can detect when supervisors are overwhelmed and distribute workload more effectively. It can identify communication breakdowns between departments before they escalate into conflicts. Human factors integration also enables more effective training and development. Rather than generic training programs applied uniformly to all staff, intelligence systems can identify specific competency gaps for individual team members and recommend targeted interventions. They can track skill development over time and validate that training actually improved performance. They can match complexity of work to capability of staff, ensuring that challenging cases get assigned to individuals with appropriate experience. Automated intelligence. The fourth distinguishing characteristic of perioperative operations intelligence is that it operates automatically, continuously, and without requiring manual data entry or analysis. Traditional systems depend on humans to scan instruments, enter information, generate reports, and interpret results. This manual dependence creates gaps in data collection, delays in insight generation, and burdens on staff who are already managing high workloads. Intelligent systems automate data capture through sensors, integrations with existing systems, and passive monitoring that requires no additional staff effort. They automate analysis through algorithms that continuously evaluate patterns, identify anomalies, and generate insights. They automate alerting through targeted notifications sent to the right people at the right time with the right information to enable effective intervention. This automation serves two critical functions. First, it eliminates the gap between events and insights. Problems are detected and communicated immediately rather than hours or days later when incident reports get reviewed. Second, it eliminates the burden on staff. Rather than requiring additional work to capture information, intelligent systems make work easier by providing visibility that helps staff perform more effectively. The Sterile by Design operating system. Implementing perioperative operations intelligence requires more than purchasing software. It requires deploying a complete operating system designed specifically for the unique demands of perioperative services. Sterile by Design OS represents this integrated platform, combining technology, methodology, and organizational capability to cure operational blindness. The technology layer provides real-time connectivity across SPD, OR, and supply chain systems. It captures workflow data automatically without requiring manual documentation. It employs machine learning algorithms that identify patterns and predict outcomes. It generates dashboards that provide actionable intelligence rather than just historical metrics. It sends targeted alerts that enable proactive intervention before problems impact patients or cases. The methodology layer establishes frameworks for decision-making, process design, and continuous improvement. It defines how leaders should use intelligence to guide operations. It specifies how teams should communicate and coordinate across departmental boundaries. It creates structures for problem-solving that address root causes rather than symptoms. It builds organizational capability to sustain improvement over time. The organizational capability layer develops leaders who know how to use intelligence effectively. It establishes competency-based progression systems that match staff capabilities to work requirements. It creates communication protocols that transform siloed departments into integrated systems. It builds cultures where data-driven decision-making replaces intuition and politics. Together, these three layers create a platform where organizations can see what is happening, understand why it is happening, predict what will happen next, and prevent problems before they occur. This represents the fundamental cure for operational blindness. Section 7. The Leadership Dimension. Technology alone cannot cure operational blindness. The most sophisticated intelligence system provides value only when leaders know how to interpret its insights and act on them effectively. This reality highlights a truth often overlooked in healthcare technology discussions. Operational blindness is not merely a technical problem, it is a leadership problem that requires leadership solutions. Sterile by Design addresses this leadership dimension through integrated development systems that transform how perioperative leaders think, decide, and act. These systems recognize that eliminating operational blindness requires simultaneous investment in both technology infrastructure and human capability. SIP's Next Step Leadership. Many perioperative leaders advance to their positions based on technical competence rather than leadership preparation. They excel at processing instruments, managing sterilizers, and ensuring protocol compliance. What they often lack is formal training in strategic thinking, change management, team development, and complex problem-solving. SIP's Next Step Leadership provides structured development pathways that build these capabilities systematically. The program teaches leaders how to move from tactical firefighting to strategic planning. It provides frameworks for analyzing complex situations, identifying root causes, and designing sustainable solutions. It develops skills in data interpretation so leaders can extract actionable insights from intelligence systems rather than drowning in metrics. It builds communication capabilities that enable leaders to bridge the traditional divide between OR and SPD. Critically, Next Step Leadership emphasizes decision-making under uncertainty, a core challenge in perioperative operations. Leaders learn how to use predictive intelligence to make probabilistic decisions about resource allocation, risk management, and operational planning. They develop judgment about when to intervene proactively versus when to trust processes to unfold. They learn how to balance competing priorities and manage trade-offs effectively. SIP's Leadership Belt System. Traditional healthcare organizations provide minimal structure for leadership development beyond initial management training and occasional continuing education. The Leadership Belt System addresses this gap by creating a competency-based progression model that defines clear expectations at each leadership level and provides recognition for advancing capability. The system begins with foundational competencies that all perioperative leaders must master: understanding workflow dynamics, reading operational metrics, communicating effectively with clinical teams, managing compliance requirements, and maintaining safety standards. As leaders demonstrate proficiency at each level, they advance to more sophisticated competencies: strategic planning, process redesign, change management, team development, and system-level optimization. This structured progression serves multiple functions. It clarifies what excellence looks like at each level of leadership responsibility. It provides motivation through recognition and advancement. It ensures that leaders possess the capabilities required for their roles rather than assuming competence based on tenure or technical skills. Most importantly, it creates organizational capability that persists even as individual leaders turn over. The system continues developing new leaders using proven frameworks rather than starting from scratch each time someone departs. Healthcare Operations Engineer Pathway. The most sophisticated response to operational blindness requires developing a new type of professional: the healthcare operations engineer. This role combines clinical knowledge, systems thinking, data analytics, and process optimization expertise to address the complex challenges that traditional clinical or administrative roles cannot solve effectively. Healthcare operations engineers understand perioperative workflows at a level of detail that enables them to design better systems. They possess analytical skills that allow them to extract meaningful insights from complex data. They have technical knowledge sufficient to work effectively with technology teams on system design and integration. They understand human factors and organizational dynamics well enough to design solutions that people will actually use. They combine all these capabilities with enough clinical credibility to influence physicians, nurses, and technicians. Developing healthcare operations engineers requires substantial investment in education and training. The pathway includes formal instruction in systems engineering principles, statistical analysis, process improvement methodologies, human factors design, and change management. It requires practical experience applying these concepts in real perioperative environments under the guidance of experienced mentors. It demands continuous learning as technology, procedures, and clinical practices evolve. Organizations that invest in developing these capabilities create sustainable competitive advantage. They build internal expertise that enables continuous innovation rather than depending on external consultants who lack institutional knowledge. They create career pathways that attract and retain talented professionals who might otherwise pursue opportunities outside healthcare. They establish organizational intelligence that compounds over time as these professionals accumulate wisdom about what works, what fails, and why. Competency-based workflow mapping. Eliminating operational blindness requires matching work complexity to worker capability more precisely than traditional approaches allow. Competency-based workflow mapping creates this precision by documenting which skills are required for specific tasks, assessing which staff members possess those skills at which proficiency levels, and using this information to optimize assignments, training, and process design. This approach begins by decomposing workflows into component tasks and identifying the competencies required for each task. Processing a complex orthopedic instrument set demands different capabilities than processing basic surgical trays. Identifying contamination on textured instrument surfaces requires different visual acuity and attention to detail than inspecting smooth instruments. Assembly of vendor-specific sets requires knowledge that may not transfer to other vendor products. Once competency requirements are mapped, organizations assess their workforce against these requirements using validated assessment methods rather than assumptions. They identify gaps where no staff possess needed capabilities, redundancies where multiple people hold critical knowledge, and imbalances where competency distribution does not match demand distribution. This visibility enables targeted training investments that build capability where it is needed most. The ongoing application of competency mapping transforms operations in multiple ways. Work gets assigned based on capability match rather than simple availability. Training becomes targeted to specific gaps rather than generic programs applied to all staff. Process design accounts for realistic human capability rather than assuming ideal performance. Quality monitoring focuses on situations where capability and complexity are mismatched. Most critically, organizations can see when growing case complexity is outpacing staff development, enabling proactive capability building before quality suffers. Decision intelligence dashboards. Providing leaders with intelligence is insufficient if they lack frameworks for converting that intelligence into action. Decision intelligence dashboards address this challenge by presenting information in formats specifically designed to support operational decision-making under time pressure. These dashboards differ fundamentally from traditional reporting tools. Rather than displaying comprehensive metrics covering all aspects of operations, they highlight the specific information needed for immediate decisions. Rather than requiring leaders to interpret raw data and draw their own conclusions, they present analysis and recommendations. Rather than updating on fixed schedules, they refresh in real time as conditions change. A decision intelligence dashboard might show a supervisor that the afternoon case schedule will create instrument demand exceeding available processing capacity by approximately 2 hours unless intervention occurs. It would identify which cases are creating the constraint, which alternatives exist for addressing it, and what the likely consequences of each alternative would be. It would enable the supervisor to make an informed decision quickly rather than spending time gathering information and analyzing options. The design of these dashboards incorporates human factors principles that account for cognitive load, attention management, and decision-making under stress. They use color, hierarchy, and layout to direct attention to the most critical information. They provide appropriate context without overwhelming users with irrelevant detail. They support both quick assessment for routine situations and deep analysis for complex problems. They adapt to user experience level, providing more explanation and guidance for newer leaders while streamlining information for experienced decision-makers. Human factors analysis. The final element of the leadership dimension involves systematic analysis of how human factors contribute to operational outcomes. This goes beyond traditional incident analysis that asks, what did people do wrong, to deeper inquiry about why people behave as they do and how work design affects their performance. Human factors analysis examines how workload affects attention and error rates. It investigates how fatigue from extended shifts degrades decision quality. It explores how distractions and interruptions disrupt workflow and increase mistakes. It studies how workspace design enables or impedes effective performance. It analyzes how team composition affects communication and coordination. It evaluates how training methods translate to actual work performance. The insights from this analysis inform multiple improvements. Work schedules can be designed to minimize fatigue effects. Workflows can be restructured to reduce cognitive load during high-risk tasks. Teams can be composed to optimize communication patterns. Training can be redesigned to better prepare staff for actual work demands. Technology interfaces can be improved to reduce user error. Quality monitoring can focus on situations where human factors create elevated risk. Organizations that incorporate human factors analysis into their improvement processes achieve more sustainable results because they address underlying causes of human error rather than simply demanding better performance. They recognize that perfection is unachievable, but predictable failure patterns can be prevented through better work design. They shift from blaming individuals to fixing systems. Section 8. The business case. Understanding the conceptual value of curing operational blindness is important. Quantifying the financial return makes it actionable. This section develops a comprehensive business case using conservative assumptions and well-documented cost data to demonstrate that investing in perioperative operations intelligence generates substantial return on investment within the first year and creates compounding value over time. Baseline scenario: 300-bed hospital. Consider a mid-sized hospital with 8 operating rooms performing approximately 4,000 surgical cases per year. This facility represents a common configuration in the United States healthcare system and provides a realistic context for financial modeling. Using conservative estimates grounded in published research, we can establish the current costs of operational blindness for this facility. Operating room costs average $50 per minute, which falls in the middle range of published estimates. Superscript 1, Superscript 2, Superscript 3. The hospital experiences an average delay of 15 minutes for 30% of cases, figures that may actually understate the problem at many facilities, but provide a conservative baseline. The facility has a case cancellation rate of 5%, which exceeds the 1% threshold that indicates significant improvement opportunity, but represents typical performance for hospitals without robust patient preparation processes. For perioperative staffing, assume 40 registered nurses experience the national average turnover rate of 18%. Superscript 1. Superscript 1. The sterile processing department employs 25 full-time equivalent technicians with a turnover rate of 25%, which is conservative given that non-clinical support roles often experience higher turnover than clinical positions. Additional costs stem from excess overtime, agency staffing premiums, reprocessing failures, and other operational inefficiencies. Annual costs of operational blindness. Case delays represent a substantial but often underestimated cost. With 1,200 cases experiencing 15-minute delays at $50 per minute, the annual cost totals $900,000. This figure accounts only for the direct cost of or time and does not include downstream effects such as compressed turnaround time creating additional delays, staff overtime from late-running cases, surgeon dissatisfaction affecting case volume, or patient experience impacts affecting market reputation. Case cancellations cost even more. With 200 canceled cases per year at an average loss of $5,000 per cancellation, the hospital loses $1 million annually. This estimate uses the lower end of the documented range of $2,000 to $10,000 per cancellation and does not account for the opportunity cost of or time that could have been used for other cases, the damage to surgeon relationships that may shift cases to competing facilities, or the patient dissatisfaction that affects market position. Registered nurse turnover costs $405,360 annually when 40 perioperative nurses experience 18% turnover, resulting in 7.2 position turnovers at $56,300 per position. Superscript 1. Superscript 2. This figure includes recruiting costs, signing bonuses where applicable, training and orientation expenses, and reduced productivity during the learning curve. It does not capture the knowledge loss, the impact on team cohesion, or the additional burden on remaining staff who must compensate for vacancies and train new hires. Sterile processing technician turnover costs $218,750 annually, with 25 full-time equivalents experiencing 25% turnover, resulting in 6.25 position turnovers at $35,000 per position. This estimate uses a conservative cost figure that may understate actual turnover costs in tight labor markets where signing bonuses and premium wages have become common. Overtime and agency costs total approximately $400,000 annually. This represents the premium costs beyond normal staffing budgets created by operational inefficiency, unexpected absences, and the need to cover gaps created by turnover. In facilities experiencing more severe operational challenges, these costs can be substantially higher. Rework and reprocessing costs $150,000 annually for instrument processing errors, wet packs requiring reprocessing, contamination events, and other quality failures. This figure covers the direct costs of materials, labor, and sterilizer capacity, but not the indirect costs of delayed instruments or emergency processing disrupting planned workflows. The total annual cost of operational blindness for this baseline scenario is $3,074,110. For a mid-sized community hospital, this represents a significant drain on financial performance, equivalent to the margin on hundreds of surgical cases or the full cost of dozens of full-time employees. Projected improvements with perioperative operations intelligence. Experience implementing intelligence systems at similar facilities provides evidence for projecting achievable improvements. These projections use conservative estimates based on observed results rather than theoretical maximum improvements. Case delays can be reduced by 50% through predictive visibility that enables proactive intervention before delays occur, better coordination between and SPD reducing last-minute scrambles, and improved workflow management that prevents bottlenecks. This reduction saves $450,000 annually. Many facilities achieve greater than 50% reduction, but conservative estimates strengthen the business case credibility. Case cancellations can be reduced by 40% through better patient preparation enabled by improved visibility into readiness, more accurate prediction of potential cancellations allowing for backup planning, and enhanced communication enabling earlier problem identification. This reduction saves $400,000 annually. Facilities that improve patient preparation processes have achieved cancellation rates approaching 1% or less, suggesting that a 40% reduction from a 5% baseline is readily achievable. Perioperative nurse turnover can be reduced by 30% through reduced operational chaos that improves work environment, better schedule predictability enabling work-life balance, improved leadership effectiveness through better information, and reduced burnout from fewer crises. This reduction saves $121,608 annually. Research has established clear connections between operational chaos, staff burnout, and turnover, superscript 2 suggesting that improvements in operational visibility should translate directly to improved retention. Sterile processing technician turnover can be reduced by 40% through similar mechanisms as nursing turnover plus competency-based work assignment reducing frustration and failure, better training targeting specific gaps, and improved recognition through objective performance feedback. This reduction saves $87,500 annually. Overtime and agency costs can be reduced by 35% through better workload prediction enabling optimal staffing, reduced need for emergency coverage due to fewer crises, improved efficiency reducing the need for extended hours, and better retention reducing gaps requiring premium staffing. This reduction saves $140,000 annually. Rework and reprocessing can be reduced by 50% through earlier detection of problems enabling prevention, better competency matching reducing errors, improved vendor management reducing variability, and enhanced quality monitoring identifying issues before reprocessing is required. This reduction saves $75,000 annually. The total annual savings from these improvements is $1,274,108. This represents a 41% reduction in the costs of operational blindness, a substantial improvement that still leaves room for additional gains as systems mature and organizational capabilities deepen. Return on investment calculation. Implementing perioperative operations intelligence requires significant investment in the first year. A realistic budget includes technology licensing and integration at approximately $250,000, implementation consulting and change management support at $150,000, leadership development and training programs at $50,000, and process redesign and workflow optimization at $50,000. The total first-year investment is $500,000. The first-year net benefit is $774,108 after accounting for the implementation investment. This represents a first-year return on investment of 155%. In subsequent years, with implementation costs largely behind them and only ongoing licensing and support costs to maintain, organizations realize the full annual benefit of $1,274,108. Over 3 years, the total benefit is $3,322,324, generating a 3-year return on investment of 564%. These figures use conservative assumptions throughout. Many organizations achieve greater improvements than modeled here. The analysis also excludes several categories of benefit that are difficult to quantify precisely, but nonetheless represent real value. Improved patient outcomes and reduced liability risk have financial value that is not captured in the analysis. Enhanced surgeon satisfaction and retention affects case volume and market share, but is not quantified. Better staff morale and engagement improve productivity and innovation in ways that extend beyond measured turnover reduction. Increased capacity utilization enables growth without capital expansion. Reduced regulatory compliance risk avoids potential citations and remediation costs. Competitive advantage in market positioning attracts patients and physicians. When these additional benefits are considered, the true return on investment likely exceeds the calculated figure substantially. The analysis as presented represents a defensible floor rather than a realistic ceiling. Scalability of the business case. The financial model scales with hospital size and surgical volume. Larger facilities with more operating rooms and higher case volumes experience proportionally larger benefits. A facility with 16 operating rooms performing 8,000 cases per year would roughly double the benefit. Smaller facilities with 4 operating rooms performing 2,000 cases would realize proportionally smaller, but still substantial benefits. The model also scales with current performance levels. Facilities with worse baseline performance have more opportunity for improvement and thus larger potential benefits. Conversely, facilities that have already achieved strong performance through other means may find more modest incremental improvement opportunity. The model presented represents a facility with typical performance, neither best-in-class nor severely dysfunctional. Critical to understanding the business case is recognizing that operational blindness generates costs in every perioperative department simultaneously. It affects OR efficiency, SPD productivity, nursing retention, quality outcomes, and financial performance all at once. Solutions that address only one dimension of the problem deliver proportionally smaller benefits. Comprehensive solutions that cure the underlying condition deliver transformational value by improving all dimensions simultaneously. Section 9. The Transformation Pathway. Understanding the solution conceptually and quantifying its value financially establishes the case for action. Executing the transformation successfully requires a structured pathway that manages change effectively while maintaining operational continuity. This section outlines a proven implementation approach developed through experience deploying perioperative operations intelligence across diverse healthcare organizations. Phase 1. Assessment and Foundation, Weeks 1 to 8. Transformation begins with comprehensive assessment that establishes current state, identifies specific opportunities, and builds the foundation for sustainable change. This phase includes current state workflow analysis that documents how work actually flows through SPD and/or identifies bottlenecks and pain points, and establishes baseline performance metrics. It includes data system audit that evaluates existing technology capabilities, identifies integration requirements and opportunities, and assesses data quality and availability. It includes leadership capacity assessment that evaluates current leadership capabilities, identifies development needs and opportunities, and establishes coaching and development plans. It includes gap analysis that compares current performance to best practices, identifies highest priority improvement opportunities, and develops preliminary transformation roadmap. Critically, this phase includes extensive stakeholder engagement to build buy-in and ownership. Transformation cannot be imposed on perioperative teams, it must be embraced by them. This requires investing time in understanding their concerns, incorporating their insights into solution design, and building their confidence that change will improve rather than complicate their work lives. The deliverable from Phase 1 is a comprehensive transformation plan that specifies exactly what will change, how it will change, when changes will occur, who will lead each element, and how success will be measured. This plan provides the roadmap for all subsequent phases. Phase 2, Core System Deployment, months 3 to 5. With foundation established, Phase 2 focuses on deploying the core technology infrastructure that will provide operational intelligence. This includes implementing data integration that connects SPD, OR, and supply chain systems, establishes automated data capture to minimize manual documentation burden, and validates data quality and completeness. It includes deploying predictive analytics that identifies patterns in historical data, develops models for forecasting future states, and calibrates algorithms to the specific environment. It includes activating intelligence dashboards that provide leaders with actionable insights, deliver alerts for emerging issues, and support decision-making with relevant information. Parallel to technology deployment, Phase 2 launches leadership development initiatives. Leaders cannot wait until systems are fully deployed to begin building the capabilities needed to use those systems effectively. Early training focuses on interpreting intelligence outputs, using predictive insights for proactive decision-making, and communicating effectively about data-driven changes. Phase 2 also includes developing and documenting new standard operating procedures that incorporate intelligence into daily workflows. These procedures specify how leaders should respond to alerts, how teams should coordinate based on shared visibility, and how decisions should be made using available intelligence. Without these procedures, organizations may deploy sophisticated systems but continue operating according to old habits. The deliverable from Phase 2 is a functioning intelligence system generating insights and a leadership team developing capability to act on those insights. Operations have not yet fundamentally changed, but the infrastructure for transformation is in place. Phase 3. Transformation acceleration, months 6 to 9. Phase 3 is where transformation becomes visible in daily operations. Intelligence systems move from providing interesting information to driving operational decisions. Leaders move from experimentation to established practice. Teams move from skepticism to adoption. This phase includes operationalizing predictive workflows where daily operations begin with reviewing predictions rather than waiting for problems to appear. Decisions get made proactively based on forecasts rather than reactively based on crises. And coordination between departments occurs through shared visibility rather than after-the-fact problem-solving. It includes implementing competency-based staffing where work assignments match capability requirements, training gets targeted to identified gaps, and performance expectations align with demonstrated proficiency. It includes activating process optimization initiatives identified during assessment, using intelligence to measure improvement effectiveness, and sustaining gains through continued monitoring. Phase 3 typically generates quick wins that build momentum and support for continued change. These quick wins might include substantial reduction in specific recurring problems, measurable improvement in key performance indicators, recognition from surgeons or administrators about improved performance, or staff feedback about reduced stress and chaos. Celebrating and communicating these wins maintains organizational energy for the longer transformation journey. Phase 4. Optimization and cultural embedding, months 10 to 18. As operations stabilize under the new intelligence-enabled model, Phase 4 focuses on optimization and cultural embedding that makes the new approach permanent rather than dependent on continued external support. This includes continuous improvement cycles where teams regularly review performance data, identify new improvement opportunities, implement changes, and measure results. It includes advanced analytics refinement where predictive models get tuned based on actual outcomes, new capabilities get added to address emerging needs, and integration expands to incorporate additional data sources. It includes leadership development progression where leaders advance through competency levels, take ownership of improvement initiatives, and begin mentoring newer leaders. Critical to Phase 4 is transitioning from consultant-led to internally led improvement. Organizations must develop the internal capability to sustain transformation momentum without ongoing external support. This requires deliberate knowledge transfer, structured coaching that builds rather than replaces internal capability, and careful management of the handoff from external to internal leadership of improvement efforts. The deliverable from Phase 4 is an organization that has fully integrated perioperative operations intelligence into its culture, operations, and leadership approach. The transformation is no longer a project, it is how the organization operates. Phase 5. Mastery and Innovation, Year 2+. Organizations that successfully complete transformation often discover that eliminating operational blindness opens possibilities they had not previously imagined. Phase 5 is characterized by mastery and innovation where organizations push beyond industry standard practice to pioneer new approaches. This phase might include developing proprietary predictive models tailored to the organization's specific environment, creating novel workflows that leverage intelligence capabilities, expanding intelligence approaches to additional service lines, or sharing expertise with other organizations through consulting or partnerships. Organizations at this phase often become employers of choice for perioperative professionals who want to work in environments characterized by clarity, predictability, and continuous improvement rather than chaos and firefighting. The transition through these 5 phases typically requires 18 to 24 months, though the specific timeline varies based on organizational readiness, complexity, and change management capability. Organizations that rush the process often fail to build sustainable capability. Organizations that move too slowly lose momentum and skepticism reemerges. The key is maintaining steady progress while ensuring that changes become embedded before adding new ones. Critical success factors. Experience implementing perioperative operations intelligence has identified several factors that consistently distinguish successful transformations from those that fail to achieve their potential. Executive sponsorship ranks foremost. Transformation cannot occur through grassroots effort alone. It requires visible support from hospital senior leadership who provide resources, remove obstacles, and communicate the importance of change. This sponsorship must be active rather than passive, with executives engaging regularly with the transformation, addressing concerns promptly, and celebrating progress publicly. Clinical leadership engagement is equally essential. Physician champions who endorse the transformation and encourage colleagues to support it create credibility that administrative sponsorship alone cannot provide. Perioperative nursing leaders who actively participate in design decisions ensure that solutions address real clinical workflow needs rather than theoretical problems. SPD managers who embrace rather than resist change model the mindset needed throughout their departments. Technology partnership between perioperative leaders and information technology departments prevents the common scenario where systems get designed and deployed without adequate clinical input. Effective partnerships ensure that technology serves clinical needs rather than clinical work adapting to technology limitations. They establish realistic expectations about what technology can and cannot do. They create mechanisms for ongoing system refinement based on actual use. Cultural transformation from blame to learning determines whether intelligence systems improve performance or simply enable more sophisticated finger-pointing. Organizations must establish clear principles that problems are opportunities for improvement rather than occasions for punishment, that data serves learning rather than judgment, and that everyone shares responsibility for system performance. Leaders who violate these principles by using data to blame individuals undermine the entire transformation. Measurement and accountability ensure that transformation delivers promised results. Organizations must establish clear metrics, monitor them consistently, communicate progress transparently, and hold leaders accountable for achieving targets. However, this accountability must be balanced with recognition that transformation takes time and that setbacks are learning opportunities rather than failures. Organizations that attend carefully to these success factors dramatically increase their probability of achieving transformational outcomes. Those that neglect them often experience disappointing results despite substantial investment. Section 10. The future of perioperative operations. The transformation from operational blindness to perioperative operations intelligence is not merely an operational improvement initiative. It represents a fundamental shift in competitive dynamics within healthcare that will increasingly separate leading organizations from those trapped in reactive management of perpetual crises. The competitive landscape is shifting. Healthcare is experiencing simultaneous pressure from multiple directions that make operational excellence increasingly critical to organizational survival and success. Value-based care models are shifting reimbursement away from volume toward outcomes and efficiency, rewarding organizations that can deliver high-quality care at lower cost. Bundled payments are making hospitals responsible for the total cost of episodes of care, eliminating the ability to pass inefficiency costs to payers. Transparency requirements are making quality metrics and cost information publicly available, enabling patients and purchasers to make informed choices about where to seek care. Quality-based reimbursement is tying an increasing portion of payment to measured performance, penalizing organizations with poor outcomes while rewarding those with excellent results. Consumer-driven selection is giving patients more choice about where they receive care and more information about comparative performance. In this environment, the hospitals that can consistently deliver on-time starts, predictable workflows, superior safety outcomes, efficient resource utilization, and high staff satisfaction will win market share, attract preferred payer contracts, and achieve financial margins. Those that cannot will face shrinking volumes, deteriorating finances, and ultimately questions about their viability. Operational blindness is becoming a competitive liability that organizations cannot afford to tolerate. Perioperative operations intelligence is becoming a competitive necessity for organizations that intend to thrive rather than merely survive. The early adopter advantage. Organizations that recognize this reality and act decisively gain substantial first-mover advantage. They develop internal capabilities that competitors cannot easily replicate. They establish reputations for excellence that attract patients, physicians, and talented staff. They achieve financial performance that enables continued investment in improvement and innovation. They create cultural momentum where success breeds confidence and confidence enables further success. This early adopter advantage compounds over time as intelligence systems accumulate data and refine their predictive models. An organization that has been using perioperative operations intelligence for 3 years possesses insights and capabilities that a competitor cannot acquire through purchase alone. The learning embedded in their systems, the expertise developed in their leaders, and the cultural transformation achieved in their teams create sustainable differentiation. The cost of delay. Conversely, organizations that delay face mounting disadvantages. While they continue managing operations blindly, their competitors are developing superior capabilities. While they lose talented staff to chaos and burnout, their competitors are building stable teams. While they suffer the financial drag of inefficiency, their competitors are generating margins that fund continued improvement. The gap widens with each passing year. At some point, the accumulated disadvantage becomes difficult to overcome. Organizations find themselves so far behind that catching up requires not just implementing intelligence systems, but also rebuilding damaged cultures, repairing fractured relationships with medical staff, recovering from depleted financial reserves, and competing for talent from a position of weakness. The question facing hospital leadership is not whether to cure operational blindness. The competitive dynamics make this inevitable for organizations that survive. The question is when to begin and whether to lead or follow. The redefinition of perioperative excellence. As perioperative operations intelligence becomes more prevalent, the industry's definition of excellence will evolve. What seems impressive today will become baseline expectation tomorrow. Organizations currently celebrated for achieving 90% on-time starts will find themselves compared unfavorably to organizations consistently achieving 98%. Facilities proud of reducing cancellation rates to 3% will be outperformed by those achieving less than 1%. Institutions that view 15% turnover as acceptable will lose staff to competitors who maintain single-digit rates. This evolution of standards creates both challenge and opportunity. The challenge is that continuous improvement becomes permanent rather than a discrete initiative with a defined endpoint. Organizations cannot implement intelligence systems and declare victory. They must continually refine their capabilities to maintain competitive position. The opportunity is that organizations embracing this continuous improvement mindset will continue widening their advantage over those that treat operational excellence as a destination rather than a journey. The human dimension remains central. As we discuss predictive analytics, artificial intelligence, and automated systems, it is essential to remember that perioperative services remain fundamentally human enterprises. Intelligence systems provide visibility and insight, but humans make decisions and deliver care. Technology enables better performance, but culture determines whether that performance improves or stagnates. Data quantifies outcomes, but relationships determine whether teams function effectively or destructively. The most successful applications of perioperative operations intelligence recognize this human dimension and design solutions that empower rather than replace people. They use technology to eliminate routine burdens so humans can focus on judgment, problem solving, and relationship building. They use data to support learning rather than enable punishment. They use visibility to enable coordination rather than create surveillance. Organizations that lose sight of this human dimension and view intelligence systems as primarily technical solutions will fail to achieve their potential. Those that recognize intelligence as a tool for enabling human excellence will achieve transformational results. The choice is clear. The hospital that sees better leads better. The hospital that leads better operates better. The hospital that operates better wins in the marketplace, fulfills its mission more effectively, and creates work environments where talented professionals want to build their careers. Operational blindness represents the invisible barrier preventing hospitals from achieving this virtuous cycle. Perioperative operations intelligence represents the cure. The data is clear. The solution exists. The competitive dynamics are shifting. The only remaining question is timing. Organizations can choose to lead this transformation, moving decisively to cure operational blindness and establish themselves as perioperative excellence leaders. Or they can wait, watching as competitors gain advantage while they continue fighting fires they cannot see coming. The transformation from blindness to intelligence, from reaction to prevention, from crisis management to strategic leadership is not simple or quick. But it is possible, proven, and increasingly necessary. The question every hospital leader must answer is not whether their organization can afford to cure operational blindness. The question is whether they can afford to remain blind. Conclusion. This white paper has defined a disease that hospitals have been suffering from for decades without naming it. Operational blindness, the systemic inability to see what is happening, understand why it is happening, or predict what is about to happen next, represents one of the most damaging and least recognized conditions affecting perioperative services today. The evidence is overwhelming. Research documents that OR time costs between $36 and $133 per minute, that case cancellations eliminate thousands of dollars per incident, That workforce turnover drains an average of $56,300 per departed nurse, and that 83% of sterile processing errors stem from visualization failures. The cumulative financial impact runs into millions of dollars annually for mid-sized hospitals and tens of millions for larger systems. Yet, despite this substantial impact, the healthcare industry has largely failed to recognize operational blindness as a distinct problem requiring a specific solution. Instead, hospitals have addressed symptoms, implementing tracking systems that document rather than prevent, hiring more staff to compensate for inefficiency, and accepting reactive management as inevitable. These approaches have consumed substantial resources while leaving the underlying condition untreated. The reason for this failure is now clear. The industry confused data with intelligence, mistaking documentation for visibility. It purchased systems designed to record what happened when what it needed was capability to predict what will happen. It invested in tools appropriate for compliance and retrospective analysis when the actual need was for prevention and proactive management. Curing operational blindness requires a fundamentally different approach. Perioperative operations intelligence provides this approach through predictive visibility that shows what is coming before it arrives, causal understanding that identifies why problems occur rather than simply documenting that they occurred, human factors integration that recognizes the central role of competency and team dynamics, and automated intelligence that operates continuously without creating additional burden on already stressed staff. Implementing this intelligence requires simultaneous investment in technology infrastructure and leadership capability. The Sterile by Design operating system provides this integrated platform, combining sophisticated analytical capabilities with structured leadership development, competency-based workflow management, and organizational culture transformation. The result is not just better data or improved processes, it is fundamentally different operational capability. The business case for this transformation is compelling. Conservative analysis demonstrates that mid-sized hospitals can achieve first-year return on investment exceeding 150% and three-year returns exceeding 500% through reductions in delays, cancellations, turnover, and operational inefficiency. These financial returns come alongside improvements in patient safety, staff satisfaction, and competitive positioning that create additional value beyond what can be easily quantified. The competitive dynamics are shifting in ways that make operational blindness increasingly untenable. As healthcare moves toward value-based reimbursement, bundled payments, transparency requirements, and consumer-driven selection, organizations that can consistently deliver excellence through superior operational visibility will win. Those that cannot will face mounting competitive disadvantage that compounds over time. The transformation pathway is understood, proven, and available. Organizations that commit to curing operational blindness can expect to require 18 to 24 months to complete the journey from assessment through cultural embedding. Those that proceed thoughtfully through structured phases, attend carefully to change management and leadership development, and maintain focus on building sustainable capability achieve transformational outcomes. The critical question facing every perioperative leader is no longer whether operational blindness is a problem. The evidence makes this undeniable. The question is whether to act now or delay. The organizations that move decisively will establish themselves as excellence leaders and create sustainable competitive advantage. Those that wait will find themselves increasingly disadvantaged as competitors develop superior capabilities. Tracking systems can document the past. Policies can outline expectations. Training can reinforce what should happen. But only perioperative operations intelligence can see what is coming, predict what will fail, interpret why it matters, prevent it from happening, and optimize what works. The hospital that sees better leads better. The hospital that leads better operates better. The hospital that operates better succeeds in the evolving healthcare marketplace. Sterile by Design is not the solution to a software problem. It is the cure for a systemic disease. The time for treating symptoms has passed. The cure exists. The choice is clear. Transform operational blindness into operational intelligence.